Thank you. Welcome, everyone. I hope everyone's seeing a little bit of sunshine today. And thanks for joining us for today's cardiac rehab work group. We're going to be talking CHF follow-up and cardiac rehab, kind of a dual topic there with a slightly different approach. We're going to have a little bit of a presentation from me, and then I've got a lovely group of panelists who are going to be having a discussion with us. And, for anyone else who's joining, feel free to join in on the discussion. We'll just have our panelists kind of lead that. All right. My name is Emily, and I'm one of the site coordinators with MVC. It's my pleasure to be facilitating and presenting a bit of this work group for you today. Just a couple of housekeeping notes before we get started. First, we are recording this session, and I will provide you with a link to our YouTube page for this recording, as well as the slides. Before the end of the day, give me a little bit of time to pull together all of those resources for you. Second, a reminder to please double check that your mic is muted unless you're speaking out and contributing to our discussion or asking a question. This just helps reduce the background noise and provide a better recording for us for later. And then finally, we will be monitoring the chat throughout the presentation, so feel free to add questions into that chat, and we'll have a designated kind of Q&A session at the end. For those attending this work group for P4P credit, we look forward to your active participation. So this today is going to include responding to a couple of polls, maybe asking a question via the chat or out loud, being part of the discussion. I will share the post work group survey at the end of the work group. That'll also be included in the post meeting email. Okay. So our agenda today, I'm going to first introduce our panelists. I'm going to go over a couple of CHF related goals and metrics that MVC is connected to. Present just a couple of relevant MVC registry and push reports. And then we'll talk a little bit about the CHF patient pathway, barriers to care, and change concepts, and connect that to the work that our panelists have been doing in this space. We'll then have our discussion and Q&A. All right, so to introduce our panelists, forgive me, there's quite a few, so I have some notes here. All right. First up is Tyler Weimer. He's a skilled exercise physiologist with over 8 years of experience in the hospital setting. Currently, Tyler serves as the cardiology supervisor at both UMH Sparrow Clinton and UMH Sparrow Carson, where she focuses on expanding cardiology services across both of those locations. So thank you for joining us, Tyler. Laura Meest has been the manager for Holland Hospital Cardiac and Pulmonary Rehab for the last 5+ years, with a background as an RN in Cath Lab for 15. Thank you for joining us, Laura. Zach Johnson serves as the lead exercise physiologist for Corewell Health's West Cardiac and Pulmonary Rehabilitation programs. Zach has been with Corewell Health, formerly Spectrum Health, for 11 years. Thanks for joining us, Zach. All right. Greg Scharf is currently the cardiopulmonary rehab system manager for MyMichigan Health. His role includes oversight of 9 cardiac rehab and 8 pulmonary rehab programs, which serve patients in 25 counties. He currently serves on the AACVPR education and Michigan Cardiac Rehab Network advisory committees and continues to represent at Day on the Hill. He's also held previous positions within the MSCVPR, including the Northern Region Representative and VP. Thanks for joining us, Greg. And Mike Thompson is a health services researcher and associate professor of cardiac surgery at Michigan Medicine, with joint appointments in the Department of Health Management and Policy and Department of Epidemiology at the University of Michigan School of Public Health. He serves as co-director of the Michigan Cardiac Rehab Network, senior advisor for the Michigan Value Collaborative, and the Director of Analytic Strategy for the Center of Healthcare Outcomes and Policy. Thanks for joining us, Mike. All right. So to start us off, I did just want to call out that there are a couple of relevant kind of goals and metrics related to CHF, which MVC is connected to. First, MVC has a couple of P4P metrics associated with CHF, mainly our 7-day follow-up after CHF value metric, which some of you may be familiar with or may have potentially selected for your site for program years 26 and 27. There are also a couple of goals to be aware of. One set by the Michigan Cardiac Rehab Network, or MyCR, with a goal of 10% of eligible CHF patients to start cardiac rehab within 365 days of discharge. And then a goal of 70% of eligible patients to start cardiac rehab within 365 days, which is a goal set by Million Hearts, the American College of Cardiology, and the American Heart Association. So just to kind of start off with some of those goals in mind. All right, and our first poll question I will launch. So if you are aware, has your site selected a CHF related MVC P4P metric, either value metric or episode spending for program years 26-27? Either yes, no, maybe that's not an area of knowledge for you, or not applicable if you're a non-P4P seeking site or another organization that's joining us today. Okay, everybody's responded. Thank you so much for engaging in that poll. Looks like most of us here today are unsure of that selection. That's perfectly fine. We're here for other QI interests, which is great. Okay. All right. So just a couple of notes on how MVC's data sort of connects to information that we have available for CHF follow-up and cardiac rehab. MVC orients our claims-based data into episodes of care spanning 30 or 90 days post-discharge. Within some of our reporting, we can also extend that episode to a full 365 days, and that is important when we're talking about cardiac rehab utilization for CHF. We know that it may not be recommended for those patients to engage in CHF within those 30 and 90-day marks, as it would be for other cardiac conditions. So just wanted to call that out for you. This is a summary table, a couple of MVC's registry reports that I thought might be of interest to you. Apologies, that looks like that slide didn't update for me. So just calling out that we have a suite of multi-payer cardiac rehab reports. If you've not gotten a chance to take a look at those, I would encourage you to. You can evaluate items like cardiac rehab utilization rates and rankings, as well as mean days and mean number of cardiac rehab visits. There's also several reports within our payer-specific suites that you may also find of interest, especially if we're investigating further into your CHF population. Okay, this is one example of one of MVC's cardiac rehab reports. I blinded this report for us, but just to show one example of what we can kind of see within the registry. This is cardiac rehab utilization within 365 days after discharge for CHF for episodes between January of 2024 and March of 2025. We can see there that MVC all average is about 6% utilization with a range of 0 to 19%. And just to call out there, again, that MyCR goal of 10% cardiac rehab utilization for CHF patients. So you can kind of see there that distribution and range between that MVC all average at 6%, goal of 10%. And if you were looking at this report, you'd be able to identify where you were kind of falling within those different spaces. Okay. Um, Lastly, just wanted to call out that MVC also includes our 7-day follow-up after CHF in several of our push reports. So just to be on the lookout for future push reports that may include this metric and might be of use to you. This is an example from our recent process measures report, which provided some in-depth evaluations of that 7-day follow-up after CHF, including ranking, 6-month intervals, and then follow-up rates by age category. Okay. Poll question 2. If I can find my polling. Went away. Okay, so my question is, which MVC data resources, if any, have you used to inform your QI work? Apologies, my polls doesn't want to pull up here. Okay, we're going to move forward because that doesn't seem to want to be working for me today. We can talk about it maybe in our discussion. Okay. So to just orient us to our conversation today, I wanted to pull up sort of a general CHF patient pathway. Obviously, we've got that admission where a patient may receive a new diagnosis of CHF, discharge, and between that admission and discharge, we obviously have some transition in care from inpatient to outpatient, follow-up care where patients are experiencing appointment scheduling and referral placements, potentially cardiac rehab, other follow-up care, other rehabs, and potentially some ED utilization and possible readmissions. So just kind of keeping this patient pathway in mind. And using the Million Hearts change package as a guide, pulled a couple of common barriers specifically for CHF patients here. So we've got barriers to referral, limited capacity for cardiac rehab programs to enroll all cardiac patients, and then patient level barriers, including things like logistics, transportation, cultural and language barriers. If you are not already familiar with the Million Hearts Change package, there's a second edition out right now, and I found it very valuable for thinking about where we could actually intervene on these kind of common barriers for CHF patients. So what we're going to do next is kind of think about these buckets of change concepts. And I'm going to ask a couple of our panelists to speak to interventions that they've been working on in these spaces. So we've got 4 buckets: systems change, referrals, enrollment and participation, and adherence. Okay. First bucket would be systems level change. So some examples of kind of things that might fall into this change concept include making cardiac rehab a health system priority, establishing champions, engaging hospital administrators and senior staff, securing that multidisciplinary style workforce, using follow-up and cardiac rehab referral, enrollment, and participation as quality of care indicators. I wanted to ask at this time, maybe if any of our panelists specifically want to speak up about any system level initiatives that they've been working on related to CHF, cardiac rehab. I believe Tyler with UMH Sparrow Clinton may have some work that you've been doing in that space.
Yeah, I would just speak to kind of having your CHF champions,
Mhm.
as well as engagement with your either hospital administration or even your physicians. I think we're pretty fortunate at UMH Sparrow that we kind of have one core cardiology group, our heart and vascular team that kind of float around to 4 to 5 different hospitals in our system, and you're working with the same team regardless of what location you may be at. They're at least from that same group. So having those champions in that group, we're fortunate that they're aware of like a multi-location system.
Great. Thanks so much, Tyler. Zach and Greg here also joining us from Systems today. Would either of you want to speak to any kind of system level initiatives that you've been working on or have been successful or unsuccessful?
I think for MyMichigan Health, kind of following up with Taylor's responses, we have a heart failure clinic group that's kind of across all of our locations. So it streamlines our communication, our expectations, and trying to cross some barriers of like best practice BPAs that we build into Epic that are distinctly different from their care planning and their process. So helping them to understand that process so that we can also be included in some of those initiatives. But it helps to have kind of a single collaborative team.
Mhm. Yeah, definitely. It's sounding like, having a like you said, Greg, a single collaborative team or sort of like a centralized program like Tyler mentioned seems to be pretty important when you're working with cardiac rehab across a system. Okay. Any other of our panelists want to speak to this systems level change concept?
This is Laura with Holland Hospital. We have a team, the Care Transitions team, which is probably similar to what others are saying. They're actually in our department physically, so that is helpful. But they also are working on, the follow-up within 7 days of discharge, those reports that come out, they're part of that. And good communication with our administrative team that schedules patients. So there's a lot of connections with that, which kind of keeps us connected to those heart failure patients, which is helpful.
Great. Thanks so much, Laura. Is that unique to Laura's team at Holland, or has anyone else been able to kind of integrate that follow-up piece into their cardiac rehab programs?
We haven't done that specifically for heart failure, but we did do that for our open heart. Um, we were integrated into their 2 week follow-up appointment to kind of bridge that gap. So I think there is opportunity based off of timing that can be successful. We had a lot of success on the open heart side.
Okay, maybe an area of opportunity for MyMichigan there. Great. All right, thanks so much. We'll move on to our next change concept here, which is optimizing referrals. Some examples of the ways this could kind of be implemented, provided by Million Hearts, was to use data to drive improvements in referral rate and process. Obviously, this is something that MVC has really tried to align with and provide resources for you. Um, and then incorporating referrals into standardized processes. Examples being adding language to echo reports, suggesting that patients with CHF with reduced ejection fraction should be eligible for enrollment in cardiac rehab, including referrals to cardiac rehab in order sets for patients with CHF, adding cardiac rehab to guideline-directed medical therapy algorithms for patients with CHF. I know you just spoke, Greg, but I think this is something that's fairly near and dear to your heart, is optimizing referrals. For those who may have been in attendance to MVC's June cardiac rehab work group, Greg spoke to this quite a bit. And if not there, our fall collaborative meeting featured a cardiac rehab focused breakout from him on this topic. Would you mind just briefly speaking about your work with referrals, Greg?
Yeah, it's kind of like I spoke a little bit earlier. It's kind of an ongoing challenge. We're not working directly with the heart failure clinic, but example would be, a lot of their parameters are based off 40%. So when I go in and ask, I'm looking at 35%. So it's another step in the process when we're building things in Epic to have another threshold to get BPAs built into Epic. So it's just another layer we have to be aware of. What we're working on now is streamlining the process of how the New York Heart Association score is documented and where that's located for us to be able to easily access that for that, and then how we document and confirm optimal therapy for 6 weeks. That's a threshold on the CMS side that we have to look at. And right now, our documentation for that is all across the board, whether it exists or doesn't. That's one thing where every provider places it is completely different. So we're always on a where's Waldo to find this information.
Mm-hmm. Zach, I believe Corewell's been working on some automatic referrals for potentially CHF patients, or maybe that was for other cardiac patients. You mind speaking to that at all? Looks like maybe we lost Zach. All right, we can always come back. All right.
He put a message in. He had
Did
some
he?
alarms going off at his.
Okay.
So,
All right. I've got so many screens up. I can't see the
right.
chat right now. Okay. Um, Anyone else on our panel want to speak to optimizing referrals, especially as it pertains to CHF patients? This could be for follow-up care, it could be for cardiac rehab.
We use a auto referral. So, it's tied to what we call power plans. So if a provider orders a power plan, it triggers it to go to a list, and then our clinical staff will screen those patients. And then if they are eligible, then we will do like a face-to-face visit with them. So I think those auto referrals through power plans it's a power plan like a order set.
Yeah.
And so that's been really helpful.
Great.
Yeah.
Carolina,
Just to
you raised
capture
your
them.
hand.
Yeah, good afternoon. I'm with Corewell, and so what we have in place is clinical pathway, which is order set for certain conditions, including cabbages. And so that works as long as the providers don't uncheck the cardiac rehab referral because it's part of the order set. So we're working with our physician leadership and as well as our peri-op team to make sure that everybody's on the same page, that that's not being unchecked. And, we have some other things that we're looking at, but that's regarding automated referrals. I think that's where we are right now.
Gotcha. Do you find that they're getting unchecked, related to this kind of the extended period past discharge that CHF patients typically experience before starting cardiac rehab, or what's the reasoning behind it being unchecked?
Honestly, I really wouldn't know. And we don't have that many patients who have these procedures. It's a relatively small denominator. And we're also, I mean, we're tracking readmissions for this population and everything else. But I think unless we speak to individual surgeons, and that probably is, going to be part of our action plans. But I really wouldn't be able to answer right now.
Yeah, that's totally fine. Megan, you also have your hand raised. Thanks so much, Carolina.
Hi, my name is Megan. I am the lead exercise specialist at Hurley Hospital. So we have a cardiac and pulmonary rehab program here. The biggest thing that I'm realizing now, like transitioning into the lead position, is that we have a daily post PCI referral list that comes to me every day.
Mm-hmm.
And a lot, it's great because it is automatic, so it's automatically sent to us. The biggest issue that we're having with it is that, say that a patient goes in for a heart cath with a possible PCI, that patient's automatically sent to us on a list, whether they get that PCI or not.
Okay.
So we're just looking to kind of implement a different strategy on how to ease patients into our program. But I mean, it's almost in a sense wasting our clinical staff's time to have to look through all of that. So I don't know if anybody uses like a different system. I mean, like I get like that the automated referrals is great, but sometimes it honestly takes longer.
Yeah. So it sounds like you've got ending up with a larger list than you really need of patients. And then we know that your time is valuable and um, especially our cardiac rehab team's time is limited. That is one of the barriers.
Yeah, because
Uh,
we're obviously we're not inpatient, we're outpatient.
mhm.
So I mean we just work Monday through Friday. So it's it's hard to kind of have like those couple days off and then come back to just a
Mhm.
really long list.
Yeah. Greg, I saw you raise your hand. Did you have a thought for Megan?
Yeah,
Or okay.
so it's kind of the same challenges I think that lies a little bit with heart failure, but one of the things in Epic, ours is actually built off of, we have another process and order set that comes off of a completed PCI.
Mhm.
So that gets rid of the diagnostic PCIs or anybody who goes in and does not, or the stent that does not get a PCI. So we kind of initially had the same thing, but then we found another trigger point within Epic and the ordering process that filtered those out. So what that looked like, that's on my Epic team more than me. But that might be something to explore is where you can get attached further down the line.
Is that something that you reached out to Epic specifically to do that?
It was more through our Epic analyst,
So you like
a hospital Epic analyst.
okay, so was it you that like kind of initiated it though and said like this is the issue that we're having?
Yeah, in our process, we do Epic change request, and that's kind of the consensus of the change request was to simply or bring us down to a level of where we can confirm that the PCI was completed.
Okay, yeah, perfect. I'll have to look into that then.
Yeah, because the reason I think the two things with heart failure, one of the concerns we have with our auto-generated process is with my chart and everything that's there, those referrals the patients receive. So once they have access, they know that it's there. It's disheartening and sometimes it's hard. And maybe from a provider perspective, that times can maybe add to that, what his thoughts are. When you're going down that pathway, a patient sees a referral and then we're canceling that referral because they don't qualify. That's not a very good conversation to have with patients. But if you're running into 25% of your referrals aren't appropriate, that's a big time gap where you're trying to have that conversation with patients, and it's not the most positive interaction.
Yeah, we do have another little issue with that too, with having CHF referrals and their ejection fractions too high to qualify for our program. I mean, those are a little less frequent than our PCI referrals are like every day, but um, yeah, well, anyways, thank you for that.
Yeah, thanks so much for contributing, Megan. I finally got my chat up, and it looks like Laura Vaughn had a comment on here. Her experience is that RNs at the cardiology practices are gatekeepers, and knowing how to communicate that with them well is helpful, and making relationships there is helpful. I'm thinking that was in relationship to optimizing the referral process, Laura, but if that's not correct, feel free to correct me. And then Laura also commented that underutilizing talent is a big issue in cardiac rehab programs. So hopefully we can continue this conversation on optimizing and utilize talent. Laura also recommends getting a receptionist. Okay, great. We will move on to our third bucket of change concepts here, which is increasing enrollment and participation. So examples of this provided by Million Hearts to optimize care coordination, using those follow-up appointments to bolster enrollment in cardiac rehab, reducing the delay from discharge to the first cardiac rehab appointment as much as possible. We know there's limitations there in terms of appropriateness of starting cardiac rehab for CHF patients, of course. Continuing to use data to drive improvement in follow-up and cardiac rehab enrollment, and developing flexible delivery models or hybrid cardiac rehab programs, which might be more appropriate for CHF patients. So looking at my notes here, I had a couple of ideas of programs our panelists are working on, but off the bat, do any of our panelists have any thoughts on QI they've been working on for increasing enrollment and participation for CHF patients?
This is Tyler. I know for us, we're kind of in a more like rural settings, like community hospitals. So with that being said, we're a little bit smaller of a facility. So we can even incorporate working with our echo team to, if they're seeing that patient firsthand at the time of initial echo, and they know that they're going to have a qualifying EF of 35% or less, kind of even putting it on our radar that, hey, we saw this patient today, and make sure you follow up, like make sure you don't wait for a referral because maybe that referral doesn't come. So it's kind of speaking to both of our increasing referrals, but then also reducing that delay of receiving that referral, because then that allows us to follow up with the physician before they even have a follow-up. We can reach out and say, you're seeing this patient on whichever day, make sure that you discuss cardiac rehab or something like that. I know that's not the case for all facilities, especially if you're in a really large facility, but maybe there are some members on here that are from smaller facilities and can take that into consideration. Another thing that we encourage for participation is also, if you come from an organization of multiple facilities, that you're making sure that they're getting referred to the location closest to them. Now, that's probably pretty much common sense for most of us, but some of us don't even sometimes always have that on our radar because we have 100 other things we're juggling, that even just taking that second glance at where's that patient traveling from, and could I get them to one of our other facilities instead.
Great. Thanks you so much, Tyler. All right. Has Zach been able to rejoin us? Zach? Okay. I had a note here that Corewell is having exercise physiologists call patients to schedule patient orientation and help explain the cardiac rehab program. It seems like another opportunity to increase enrollment and participation. You've got a very knowledgeable person calling you and providing that information. Is anyone else working on um, similar projects, kind of having EPs be involved in calling and scheduling orientations or education sessions, something similar to that.
Emily, this is Laura.
Hi, Laura.
A little bit off of that, we're going to do some strategies focusing on the heart failure population and implementing a group orientation with these patients, try to capture them before the 6 week.
Yeah.
So about 2 to 3 weeks after discharge, it would be like an orientation for about an hour, and we'd hold that weekly for just depending on how the volume of patients.
Mhm.
And just to introduce them to the program and the expectations and doing baseline surveys and all that would just be non-billable. So just something to try to capture those heart failure patients before the 6 weeks.
Yeah. That was gonna be my question was, is it billable? Probably not. But sounds like a great opportunity to start developing some rapport, which we know is really important for that, maintenance of enrollment and continued participation in cardiac rehab. Okay.
One one of the things we talked about, I don't know if any on the call or have a combined cardiac and pulmonary rehab program. One of the challenges we always find with heart failure patients is they're vastly different from our intervention cardiac patients.
Mhm.
They align. I always feel like they align much more with our pulmonary rehab patients as far as process symptomatic, symptoms, management of disease is all the focus in pulmonary. We've discussed the concept of do we do them in a pulmonary, under our pulmonary side with our, with those patients to kind of mix more similar, to kind of promote some more networking for them and support for them. Even though the disease process is different, the symptoms and the approaches are much similar on the pulmonary side. So that's something we've tossed around for a little bit too. So I don't know if anybody's explored that or have more of a mixed gym setup.
Yeah, it's really interesting, Greg. Okay. All right. Doesn't sound like anyone has a similar setup, but that sounds potentially really promising. Greg would love to hear more about it in the future, as you guys continue and investigate that. Catherine from Corewell asked on one of MVC's work group calls last year. Yes, it was our first cardiac rehab work group last year. Someone mentioned remote cardiac rehab. That was a presentation from Dr. Catan from Henry Ford. He spoke to their hybrid program. I don't know if there's anyone from Henry Ford here, anyone from, I believe Michigan Medicine is working on kind of a pilot um, hybrid program. Um,
Sorry, Emily, did you say U of M is working on one?
Mike just offered to speak to that a little bit, and then we actually conducted a survey through MyCR. Hi, Zach. um, recently, and I think Mike was gonna present those results. Just very briefly speak to it.
Great.
Yeah, I mean, just kind of broadly speaking, I think we had tried to get some information about some of our sites around the state, and we got I think like 27 different responses, and there's a handful of sites around the state that are actively doing kind of virtual or remote programs, um, but they're not many. And although there is a lot of interest, and so I
Yeah.
think we're trying to learn more about, and hopefully with the extension of Medicare reimbursement for another 2 years, that may give people a little runway, hopefully to experiment or innovate in that space.
Yeah.
And we're going to keep kind of seeing what folks are doing, and if there are things that we can do to disseminate, best practices or things that folks are doing around the state, that's we're gonna try to do. And I think that the 2 year extension gives hopefully people a little wiggle room to be able to have that be part of the program.
Yeah.
Yeah, I'm just so curious what the compliance rates look
Hmm.
like for, something remote versus if it has to be in person, and then like what the outcomes would be. It was just I thought it was such an interesting topic. I didn't even realize you could do something like that remote. But what a great opportunity to maybe get patients in on a more regular basis.
Yeah, Catherine, if you've not watched the recording from Dr. Catan's presentation on Henry Ford's program, I'd encourage you to
Great,
take a look at that. I can send you the link
great. I love
if you
that.
don't want to go looking through our YouTube page
Yeah, it'd be
for
great if you
that.
could
But
send
he
it.
does walk through at least preliminary results
Okay,
from their program in terms of retainment and everything that you were just asking about.
great.
Um, as part of Heart Week, we will also be sharing an infographic and a blog summarizing those survey results that Mike just called out as well. So be on the lookout for that. It'll come from my CR.
Great, thank you.
Yeah. Okay, so our last change concept here is supporting adherence, which we've kind of been talking a little bit about. I feel like there's some overlap between supporting adherence and our previous topic, but some of the specific areas called out by Million Hearts were to identify populations specifically at risk for lower engagement and try and engage with those patients, addressing patient social needs, for example, transportation to cardiac rehab, incorporating motivational and financial incentives to enrollment and continued engagement, and then automated reminders and communications with patients. Um, kind of spoke to a couple of these ideas already. Since Zach's back with us, I wanted to see if you'd be able to speak a little bit to Corewell's um, uh, open houses, support groups, and then I believe there was a partnership with Rehab that you guys were working on. Would you mind speaking to that?
Sure. Yeah, so we like Emily had said, I mean all of our patients who do come to us, they do have the ability to meet. Well, we have a support group where we have patients that have formally completed or have already completed the program. We have patients that are getting ready to start our program, and then current patients as well. Our support group meets every quarter. So one of our staff here, he will sit down with all those patients in our education room and um, eh, get all these patients together, and so that way they can sit down and they can talk about the different events that they've went through that have kind of led through their cardiac journey. We've had really good results from doing that with getting patients to really buy in. I say buy in to really say yes, I want to keep coming to this program. I'm seeing the benefits. I'm meeting new friends. I'm hearing other stories and other people they can relate to other people that they've had these same events that have happened for them. And then you had mentioned something about transportation. One thing that we do as well to help get our patients to come through, we have partnered with Michigan Rehabilitation Services. So with that service, what it is if we have a patient, say, who has a $20 copay or a $50 copay, they will cover that copay for the patient. But the one caveat to it is the patient does have to be working or planning to return to work at least 20 hours per week. So once they are able to go through the authorization process, then they will cover everything for the patient that they will have outstanding. Some of our other regional locations, we do have what's called True North. That is a donor family who has donated a certain dollar value, and patients who are at a certain poverty level, they are able to qualify for that program. So if they don't have the funds to potentially pay for the out of pocket of what's going to cost to come to rehab, they will pick up the cost of that program. And then also at our Ludington location, we do have a a ride service. So they will go and pick these patients up and bring them to all of their appointments. And that can be for cardiac rehab, that can be just for their traditional office visits with cardiology or even primary care. Any visits can relate to their health, they will offer that service to them.
Great. Thanks so much, Zach. I'm glad you're back. Hopefully those are alarms turned off.
They're off and patients doing okay.
Okay, good. Great. Um, Does anyone have anything else to add in terms of initiatives you guys are working on for contributing to supporting adherence? I think Laura Holland is also working on some copay assistance programs. Okay.
We were given the mini grant through Milligan.
Yeah.
Yeah, so that's part of that heart failure group orientation and then also copay assistance. So we're working through all the little details with that. So
Awesome.
yeah.
Sounds good. If you guys are not familiar with the mini grant program, Mike might be able to speak to it more, but is a program through MyCR that we've offered in the past to support some of these, various projects that might not otherwise have some direct funding or copays to kind of help support. So, yeah. Okay. Great. Okay. I think that kind of finishes off our discussion around change concepts. Thank you so much to the contributions from our panelists. I did have a couple of additional discussion prompts here. Some of these we've already touched on a little bit, but I wanted to open the floor to anyone else on the call today who had some thoughts related to any of these discussion prompts or wanted to contribute to the discussion at all. That first discussion prompt is what unique challenges have you identified when working to optimize follow-up care or enrollment in cardiac rehab for CHF patients? And I think we've had a couple of examples of those come up from the layers in Epic or other EMRs that you might have to negotiate for these patients. Those auto referral systems that might be capturing more patients than are eligible for cardiac rehab, amongst other examples. Does anyone have any thoughts that have not been brought up yet today regarding the challenges for CHF patients?
I think my question would be from, maybe Dr. Thompson on like from a provider perspective, knowing the variance and the layers different between, typical, I won't say typical heart failure treatment pathways, but from your perspective, the timeline between when you see a patient at 40 and getting to 35, what are some things that we could do to help promote that? Because I think a lot of times those ships have sailed on treatment for that. And then does it come to realization when they hit 35 that, okay, now they qualify? Does that change is there something that ties into that in your treatment with heart failure patients that we could align with? But I feel like a lot of that's already left the station and we're just behind.
Yeah, so I'm not a clinician, but working with a lot of clinicians in the space, I think they talk a lot about, um, and I know Stephen Katan has said this before, that essentially like at any point, if their EF is 35 or below, they are immediately referring them for cardiac rehab and keeping an eye on that. And it may change from test to test, but essentially using a single opportunity, a single measurement of 35 EF as a way to kind of start the process. And even for those that are in that kind of 35 to 40 range, it's something that they're already talking with their patients about. In that, at least introducing the ideas of cardiac rehab as, based off of progression of disease, or this is where, you have been trending towards the last, few years or months. These are things, starting those conversations before they get to that point as an option for them, once they get to that point, is something that I know many of my colleagues have tried to do, although, like you said, it is very challenging to even to keep that in line with many of the other things that are going on. And so I think they often try to get those conversations started before they get to that point, recognizing that it can be that the challenges of that 35 cutoff are still real and make it hard to get those referrals in beyond that.
Great. Thanks, Mike.
I would just add to that point for you, Greg, that we had a lot of those challenges too of like that 35% cutoff, and that's where we kind of had to go back to our cardiac like group, our physician group, and kind of just reiterate the fact that 35 is a hard line for us. We kind of would think some of us unfortunately assume that our physicians know that because we know that, but kind of bringing that back to attention for them, kind of like then put it back at the top of their mind sometimes when they're looking at a patient and even, dictating echoes and things like that. I'm not saying that they're going to skew the numbers by any mean, but when you're kind of making that general report, are you reading it 30 to 35 or 35 to 40? Because that could be a huge difference when it comes to qualifying.
Thanks so much, Tyler. Okay, with an eye on time, unless anyone had any other burning questions or thoughts, I'm going to move on to just a couple of PSAs. First, as I've mentioned, it is Cardiac Rehab Week or Heart Week. So with the Michigan Cardiac Rehab Network or MyCR, these are a couple of the ways that you can get involved. So we'll be pushing out lots of LinkedIn materials. If you've not followed MyCR on LinkedIn, I would encourage you to do so. So you can follow us on via BMC2 and MVC for some daily updates, and feel free to repost. Can also share your cardiac rehab journey story using a secure patient submission forms. This is like a recorded opportunity. Record a brief phone message in support of cardiac rehab and why it matters to you, 2 recording opportunities. And then this one's sort of fun, printing out the cardiac rehab is important to me because sign, share your why and take a selfie with your why. And I would encourage you to post that to LinkedIn as well. All right. Just a couple of additional cardiac rehab resources, of course, MVC's Cardiac Rehab Initiative website, as well as those reports that I mentioned earlier. MyCR also has their own website and resources, and BMC2 as well. And then, of course, the Million Hearts Cardiac Rehab Change Package, I linked there for you since I referenced it throughout the presentation today. MVC has a couple of upcoming work groups. This is actually our only work group for the month of February. We will have a virtual networking event, which I'll call out in just a second here. But in March, we will have 2 work groups, a rural health on Tuesday, March 10th, and a post-discharge follow-up work group on Thursday, March 19th. We have a virtual networking event coming up later this month on February 26th. That'll be from noon to 1:30. You are welcome to register for that now. And then just a reminder that MVC Spring Collaborative Wide Meeting is coming up on May 8th, and that's going to be up in beautiful Traverse City, Michigan. So we look forward to maybe seeing a couple of you there. And lastly, MVC is seeking presenters for 2026 for our work groups, meetings, and other opportunities. So if you have a QA project or a presentation that you'd like to share, feel free to submit a presentation proposal form to us, and we will work with you to help develop that presentation. And Jessica has just shared the form for our post-meeting survey. You can go ahead and grab that. I will also include it if anyone needed to leave. I will also include that in the post-meeting follow-up email. Thank you so much again to our panelists for contributing to today and for bearing with me as we recreated this work group. All right. Thank you so much.
Thanks, Emily.
Thank you. Jessica, can you stop the recording?